I'm Peg Squier, Group Vice President of U.S. Medical Affairs at Incyte. What's happening at ASH for Incyte this year? Well, I think four big things for the MPN community. First, of course, the big theme in myelofibrosis is combination therapy. Ruxolitinib had its anniversary this fall for 10 years since the first approval in the United States for patients with myelofibrosis. And now we have a lot of new agents coming out with promise for the disease. A lot of these agents seem to have good activity as monotherapy, but they seem to have even more promise in combination with ruxolitinib. And for Incyte, we presented additional data for our combination of ruxolitinib and parsaclisib. And of course, this combination is now in phase 3 global trials in the frontline setting and also in patients who've already been treated with ruxolitinib and either have had a suboptimal response or have lost part of their response. Second thing is when to begin treatment in myelofibrosis. So we did an analysis of our COMFORT trials with ruxolitinib. These are the completed studies that led to our approval. And we found that if you separated the patients who initiated treatment within 12 months of their initial diagnosis and compared them to patients who started treatment after 12 months, that the patients who were treated early had a better chance of responding. They had deeper responses. They tended to have fewer adverse events, and they had the potential for improved overall survival. So, of course, these were intermediate 2 and high risk myelofibrosis patients, and it'll be important to see if this early treatment effect generalizes to other studies in a broader patient population. For Polycythemia Vera, we presented results from the REVEAL real-world study, and this is, of course, a study of more than 2,500 patients in the U.S. who have Polycythemia Vera and receive any of a number of kinds of therapy. We were able to do an analysis of more than 2,200 of these patients, tracking thrombotic events, which of course are a major risk for people with PV, and correlate that with their blood counts. Of course, in PV, lowering the hematocrit for these patients to 45% has been a major therapeutic target for some years. And one important finding that the authors presented in their oral presentation was that even when hematocrit is controlled to 45%, white count is an independent risk factor for these patients. So getting the white count down may be a second therapeutic target. And then finally, we know in myelofibrosis that there are major driver mutations that can lead to the disease. JAK2, MPL, CALR are the 3 major driver mutations in MPNs, but there are rare mutations that can lead to myeloid malignancies. And one that we presented oral presentation for is patients who have myeloid or lymphoid malignancies who have an FGFR1 alteration. And it looks like these patients might have treatment with an FGFR inhibitor that we have called pemigatinib. This is already approved for patients who have a solid tumor called cholangiocarcinoma who have an FGFR2 alteration. So for this rare orphan indication, we have some activity data to present and potentially hope for these patients. So those are 4 highlights for you. Wishing that all of the data across the board for ASH is useful to you and that we have more results to present at future meetings. Thank you.